everyone, we're back for another episode of Cancer Specialist Medical Minute.
Welcome back, guys. I'm Dr. Danny.
Dr. Rick over here.
All right. This is appropriate for my son who runs track. Rick, what do sprinters eat before they race?
Pasta.
No, nothing. They fast.
It's cute.
Thank you.
It's a good one.
Thank you.
Your son Ethan is pretty fast, right?
He's pretty fast, yeah. Brent and I were talking about how wonderful track meets are, how they make you stay for 8 hours long, all day long, watching your kids sit and wait for their next race.
It's bad enough being the kid, let alone the parent. Sounds awful.
Yeah. So most of us are on our phones doing other things, but cross country is much better because they run in groups. They're done in 10 to 15 minutes. Then you go home.
That sounds
So
nice.
I'm going to support cross country racing from now on.
I would too.
All right.
So I think we're here to talk about head and neck cancer.
We are, Rick. Do you know where head and neck cancers normally start?
In the head and neck?
That's correct.
Is that another bad dad joke?
I could make one.
Please
What do you think?
Don't. That's not.
No, you're good.
So, yeah, I mean, there's a lot of subsites of head and neck cancer, depending on, where anatomically the cancer starts, kind of going up, working our way from the top to the bottom. You have the sinuses, you have the nasopharynx, which is the part of your pharyngeal axis that's behind the nasal cavity. And you have the nasal cavity, you have the oral cavity, which is the tongue, your teeth. You have the oropharynx, which is your base of tongue, your pharyngeal wall, your tonsils, all the way down to the hypopharynx, which is your piriform sinuses, posterior cricoid area, your larynx, which is your vocal cords, your area epiglottic folds, your epiglottis, your subglottis area. So
Sounds complex, Rick.
it's a very anatomically challenging area to treat from my perspective as a radiation oncologist, and surgically from a ear, nose, and throat doctor's perspective. It's a very challenging area because you have a lot of very important things in a very small space.
Right. And probably nowadays, and we'll get into different treatments and how we approach treatment nowadays, but also different risk factors for developing head and neck cancer. We saw a lot more of patients coming in with really long smoking histories, and we still do to this day see head and neck cancer related to tobacco use, also alcohol use, and but we're seeing a little bit more of a incidence in HPV-related cancers, and most head and neck cancers are squamous cell carcinomas, so developing on the lining of the inner mucosal layer of the head and neck region, wherever it originates from. So have you seen, Rick, the HPV-driven cancers? And we can kind of get into that a little bit more, but a certain area that they develop more commonly?
Yeah, so yes, and the answer there is there's been a clear rise in oropharyngeal cancers, so cancers of the base of the tongue and the tonsil. Most commonly, those are the ones that these days typically are HPV driven. So HPV is human papillomavirus, very common virus that most Americans get at some point, usually in their childhood. And then now we know that in some cases there are certain subtypes of HPV that are higher risk for causing these cancers, typically of the oropharynx, the anus, and some GYN cancers. But we're here obviously to talk about head and neck cancer today.
Right.
There's a vaccination series now available for both young men and women to reduce the risk of HPV cancer. Originally thought to be mostly for cervical cancer, but now we're obviously seeing it's going to hopefully reduce the risk of head and neck cancer going forward, because I still think predominantly most head and neck cancers have some tobacco association. Like if you look at all the subsites taken together, but the part that's clearly on the biggest rise is HPV-driven oropharynx cancers.
Right. And sometimes you see HPV positive cancers that develop in smokers. Sometimes you see them in non-smokers. But a lot of time, like you said, you're seeing a patient who had some either relatively recent or remote history of smoking in their lifetime.
It's very rare we find head and neck cancer in a completely non-smoker, but it is something we do see occasionally.
Right.
The studies that really looked at HPV and its association with oropharynx cancers and kind of how well these patients did one of the big stratifying factors is smoking. So someone who's a very, very heavy smoker has cancer in the head and neck, but it somehow is HPV related, those actually won't do as well as someone who's never smoked or has a very minimal smoking history, despite having an HPV-driven cancer. So there is some outcome stratification based on smoking, which is kind of interesting because you would think all HPV-driven cancers should behave the same, but they really don't. But yeah, so in general, to your point though, the biggest risk factor is oral. So you got to be careful. There's also oral tobacco. So chewing tobacco is a very big risk factor, especially for mouth cancers or oral cavity cancers. And then of course, smoking, like so many other cancers, is probably the number one risk factor.
Right. And have you seen a trend for, in your field, treating patients with radiation therapy, a trend to administering radiation therapy more commonly than doing surgery in certain sites where this cancer develops?
Yeah, so this is definitely I wouldn't call it a hot issue in oncology, but it's a very often debated issue. I think, historically, almost all oropharynx cancers, so again, base of tongue, which is the back of your tongue,
right,
and the tonsils, historically, almost all those patients received definitive radiation. One, because the outcomes were so good and patients could tolerate it with expected side effects that we could manage. What's changed recently in the last, not was it recent as in 5-6 years, before surgically, in order to do a good resection, like if you were to take someone's tonsil out, the type of surgery you would have needed back before the advent of the robot would require basically ripping your jaw in half and getting in there and getting the tumor removed, which is a very morbid procedure, and patients' quality of life was a disaster. So they really abandoned that. But now with the robot, there's some thought of, can we get in there, remove it surgically, preserve some swallowing function? Unfortunately, I think that when you look at the data with an open and critical mind, the outcomes for surgically treated patients tend to be worse from a swallowing standpoint and no better cancer outcomes. So whether there's a utility for a lot of patients with surgery in that situation, I think I'm obviously a little biased. I think the answer is no. The only patients I would really push for surgery would be if they had a very, very small, very early stage tumor where you think you could remove it, preserve their swallowing function, and they wouldn't need anything after. Because the biggest issue is a lot of these patients end up going to surgery, then they end up needing radiation after, almost all of them, or vast majority of them, plus or minus some chemo. And so now you've added another modality of treatment that maybe you didn't need when chemotherapy or radiation plus or minus chemo would have taken care of the job.
Yeah, you look back at the long-term data or outcomes and they're the same, you know.
And then they have all these extra swallowing issues because, part of their throat and swallowing apparatus has been removed. Right.
Yeah, in terms of, our field, medical oncology field, we haven't changed much in how we administer our chemotherapy during radiation treatment. There's been probably the hottest topic is, do we need to give as high of dosages of chemotherapy that we gave in the past for these patients? We were giving a drug called Cisplan, which is a chemotherapy given IV, and we would give it at really high dosages, and we still do for some patients today, but you can imagine a lot of toxicity from that chemotherapy, hearing loss, neuropathy, kidney problems. So we try to, if we can, give it at a little bit of a lower dose in more of a frequent schedule, giving it weekly, which has a little better tolerability. But the data hasn't teased out whether that's exactly the same as the high dose. I think there's some studies that allude to that it may be, and it may just be the dose that you're giving the patient, the total dose during their radiation treatment.
I was reading some study that showed basically if going from the 30 to 40 weekly kind of makes that huge difference in outcomes.
Yeah, that dosing, the total dosing, I think is the most important.
Well, I can just tell you from my perspective, when we treat patients together, and they're getting weekly chemo versus the bolus chemo. I mean, because we as radiation doctors, we see patients weekly when they're under treatment. So we kind of see them a lot, and those patients definitely tolerate treatment much better than those who get the bolus therapy. I mean, it's pretty, from like just the anecdotal perspective of a very different experience.
and we would give in fellowship. Majority of the time, I was giving the bolus dosing, the high dose, and a number of times you couldn't give the third dose
Right.
because it was so toxic. Hearing loss, kidney problems. Again, you're not going to sacrifice, some organ function, at the expense of a cure, in most cases. So that's why the weekly dosing, and it's good to see the data to show that you can give it weekly, less toxicity, and just about the same outcomes. And with the lower dosing, the 30 milligrams that you talked about, I think the data kind of showed there were more potentially local recurrences. I don't remember the distant recurrence rate on that study, but it was a little bit less effective than the bolus dosing. But there really hasn't been a drug that has surpassed cisplatin as a radiosensitizing chemo, so we use it in a majority of cases
An oldie but a goodie.
As long as the patient can tolerate, we feel like their function's good enough to tolerate it, they get it. And I think there is some data that's probably coming out more. I've seen a few smaller studies to maybe even omit chemo in certain cases of HPV-driven cancers, and there's a lot of studies that are ongoing.
Yeah, I think that where this field is heading is, like everything else in medicine, kind of trying to see, can we stratify people based on certain tumor characteristics, and say, do we need to escalate therapy or intensify therapy, or in some cases, can we de-escalate or give less and they do just as well and therefore have better long-term functional outcomes. So that's really, there's studies looking at lowering the chemo dose or omitting chemo, lowering the radiation dose, lowering the radiation treatment field, so where we treat. We talked about surgery briefly already. So it's a rapidly evolving area. I will say as of, March 18th, 2022, there's been no phase 3 data yet to show that you can safely de-escalate. There's been a lot of good, highly suggestive phase 2 data and some currently enrolling phase 3 trials. But, when I see a patient still in clinic today, even if they meet some of these lower risk criteria, you still have to tell them that the standard of care is kind of the historical standard, because we don't yet know for sure long-term are these patients' outcomes going to be the same. So it's a very exciting, actually, I think, place to be, because I think in the next probably 5 years we'll have some good data showing in certain situations what we can do to back off either from the chemo side, from the radiation side, or both, to allow these patients to hopefully have some less side effects long term.
Right. What do you think as far as the stereotactic radiotherapy techniques and giving more dose less frequently? The toxicity is obviously a main concern if you're doing that in the head and neck region.
Like SBRT or stereotactic radiation right now really is only reserved for the re-irradiation setting. So patients who've had head and neck cancer, had radiation, and then if their cancer unfortunately recurs in a radiation field, those are the times where we're really implementing those technologies, where you're really just targeting the small area where the tumor has come back. Because a lot of times with head and neck cancer, when this is kind of something that can be tough to explain to patients, is the tumor may be in the back of your throat, but we need to treat the necks where all the lymph nodes hide, because most of these head and neck cancers have at least a 25+% risk of having microscopic disease in their neck, even if their neck is completely clear on imaging and scans and all that sort of stuff. So, we end up treating a much bigger area, I think, than most people realize during treatment, because we have to cover these areas, because we know if we don't, they're going to have recurrences in their neck, and that can be, morbid and potentially fatal to deal with. So it's a very interesting space for the radiation oncologist, because depending on the location of where the tumor is, we cover, all these different areas, or some areas we don't, and it's a very nuanced part of our field. Definitely something that's one of the more labor-intensive things we do, because it's such a very important real estate. There's a lot of important structures there. So how we design the radiation plan, the head and neck is definitely one of our sites that requires the most insight and thought and technical know-how to do appropriately.
does. Yeah, a lot of precision and
Yeah.
planning.
And I think, the other thing is that, like you said earlier, most of these cancers are treated with chemotherapy and radiation or radiation alone. Cancers in the mouth, so the teeth or the tongue or the gums, those cancers are managed surgically. So surgery is actually the most important part of those cancers, usually followed by radiation plus or minus chemo. But I just wanted to let the listeners know that's kind of one of the big deviations there is oral cavity cancers is a surgical disease, whereas the vast majority of other head and neck cancers are not. There are some other rare types of sinus cancers and things that are surgically managed, but for the most part, it's not really a surgical. Most of these are not primarily managed surgically. And then also just very advanced larynx cancers can be should be managed with surgery up front.
Mm-hmm. Viewers may ask, are we using immunotherapy during, head and neck cancer treatment, chemo and radiation? I'm sure there's a trial. I can't think of what trial they have investigating that, but I know, for lung cancer and a few different cancers, we're looking at it in the preoperative setting, throwing in an immunotherapy drug in with chemo and sometimes with radiation. And so I'm sure there is a protocol out there.
I think there's like phase 1 or phase 2 data for concurrent chemo immuno RT.
Right.
I actually don't think what I saw was that the outcomes unfortunately were not improved. And of course, then you got the added toxicity benefit. But I think in the metastatic setting, there's some good data.
In the metastatic setting, depending on the PD-L1 status, which is the biomarker we kind of use to see if patients are more likely to respond to immunotherapy, that you can use it in combination with chemotherapy or even on its own, depending on that PD-L1 expression, which is, again, something we measure on the tumor cells. So, but yeah, anywhere outside the metastatic setting for head and neck cancer, we're not really using immunotherapy. It would be interesting to look at whether some of the stage 4 cases, which patients with bilateral neck lymph node involvement and pretty big tumors, if maybe there's some utility in using immunotherapy in the more locally advanced setting, but I don't know of any data right now.
Yeah, it's hard. I mean, I think, in my opinion, if the one area where I think it might help would be in the disease sites where you worry more about distant disease popping up than local regional recurrence. The vast majority of head and neck cancers it's a local regional problem. But there are certain types, HPV specifically, that like to go to the lungs and other areas. So maybe those are the ones that, we can stratify and figure out who may benefit from immuno or some other escalated systemic therapy. So yeah, I think it's definitely an interesting.
And it doesn't tend to be a cancer that really has other targets for medical oncologists. Like, we're not seeing activating mutations like we are in the lung. Squamous cell carcinomas generally don't have as many activating mutations that you can target with a pill, like sometimes we can with different lung cancers. So a little frustrating that we can't have more precision medicine for head and neck cancers. But
yeah, I think one of the only sites I can think of is the nasopharynx. There is data looking at nasopharynx has another virus associated with it, the EBV or Epstein-Barr virus. And so that one, there's some data showing you can measure their levels of the viral titers pre-treatment, post-treatment. And then, folks who have a good response from initial chemo radiation may not benefit from any chemo on the back end versus those that still have residual titers may benefit from chemo on the back end. So that's about all I can think of in terms of sort of maybe, more targeted systemic treatments, or at least targeting the patient, the appropriate patient to do it in. So I think it's probably an unmet need, and hopefully we can, research can address that going forward.
I know with EBV and sometimes with even lymphomas that are EBV driven, you get rid of the EBV or the B cells that it's hiding in, that the disease gets better, with lymphomas. So I'm sure there's some data out there that maybe suggests that, like, getting rid of where the EBV the virus is making a home in the immune cells, getting rid of those immune cells, and thus the stimulus for cancer development, probably helps. But I don't know of the data offhand for that.
Yeah, no, and I think we touched. I don't think we went into too much detail on it in our screening episode, but one of the questions people always have is, well, is there screening for this? Should I get scans? And the answer really, the main thing is seeing your dentist. So,
Yeah.
it's an under talked about area, but your dental practitioners, when you go in for your twice a year just regular dental visit, should be doing an oral cavity tumor screening where they look under your tongue, they look in the sides of your mouth, on your gums, obviously roof of your mouth. So that's one step that encourage you. You should go see your dentist because you should have good dental care, because it's important for other health aspects in your body. But in the cancer realm, it can be a detection method for oral cavity cancer. Outside of that, there's really not much of a role for routine screening, but certainly if a patient developed certain symptoms, so chronic like nasal congestion that didn't respond to antibiotics and other treatments, and it was persistent and you didn't know why, those are the patients, you may see it into an ENT doctor or do a scan on. Unexplained hoarseness that's persistent, that doesn't have any other explanation. Trouble swallowing that doesn't really have any other explanation, and that's persistent. What other things would you tell a patient if they had? Would you be worried and maybe have them see an ENT doctor?
And again, if you're seeing a dentist, you think the dentist would pick up on a sore in the mouth that doesn't heal, and it's not just a standard canker sore that lasts a week or two, but something that doesn't heal and is present for longer periods of time. You think about any kind of bleeding, if you're at all coughing up blood, that could be, it doesn't mean it's coming from your lungs. Sometimes it's coming from the back of your throat. And so that's definitely an abnormal symptom that someone should get investigated right away. Any kind of discoloration, I think, in the mouth, if they're brushing their teeth or examining around their teeth and they see discoloration in the gums, worthwhile getting checked out. And just if they feel a lump that is abnormal, ask your doctor or your dentist about it. So I think those are the main things I would think about. There are some rare circumstances with, like you mentioned, nasopharyngeal cancer. If you again have sinus pressure or even headaches that keep recurring and you don't know why, like you said, congestion. Trying to think of the other presentations I've seen. I think a majority of them have been.
Ear pain is a common one. You can get referred to ear pain from some of these tumors depending on the location. So that's something that if we talk about hoarseness, but there's also voice changes that can sometimes indicate there could be something going on.
Right.
I think it's or certainly you may have mentioned lump in your neck. Sometimes, especially these HPV cancers, sometimes they present more with neck lymph nodes. So the patient comes in with a neck mass. They don't even know there's anything wrong with their tonsil because they can have a very small primary, but very impressive adenopathy. So it's,
I think we've had a case or two like that where it just presents with a lymph node enlargement.
Those cases is pretty common that a patient comes in just with a neck lump, and then they end up, finding out it's coming from the tonsil.
Right. Yeah. Thanks so much for coming back and joining us for another episode of Medical Minute.
If you have any suggestions on things we should talk about, questions you'd like answered, or you just want to say hi, please email us at medicalminute@csnf.us.
That was perfect, Rick.
Thank you.
And make sure you follow us on social media. Search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram.
And as always, we appreciate you giving us a few minutes of your time, and we hope you learned something today.
And remember, when it comes to your health, stay informed.
Ask questions.
And tune in next time.
Nice.